Good day. Welcome to Clinical Pharmacy and Pharmacotherapeutics 2. Particularly, we will be discussing the respiratory system diseases, COPD, or the chronic obstructive pulmonary disease. So, for my disclosure and disclaimer, this presentation is for pharmacy educational purposes only. Some presentations were taken from the teaching slides of Global Initiative for COPD or GOLD. Any brands, proprietary products, devices mentioned in this presentation is not sponsored nor has intentions for commercial purposes. The lecturer is not affiliated to any pharmaceutical company or sponsors, and learners are also encouraged to perform their own assessment, research, and evaluation on the information discussed in this presentation. Further, this lecture is not a substitute to any direct clinical judgment. So let's begin with the discussion of COPD or chronic obstructive pulmonary disease. Let's first define COPD. So basically, COPD is characterized by airflow limitation that is not fully reversible. When we talk about airflow limitation, in COPD, this is described as progressive and abnormal inflammatory response. So based on the National Institute for Health and Clinical Excellence in 2010, they defined or characterized COPD as an airflow obstruction with a reduced forced expiratory volume and forced vital capacity ratio of less than 0.7. Now, if the forced expiratory volume is more than or equal to 80% of the predicted normal, a diagnosis of COPD should only be made in the presence of respiratory symptoms, for example, breathlessness, or cough. COPD covers a variety of other disease labels, including COAD, or what we call chronic obstructive airways disease. It also includes COLD, or the chronic obstructive lung disease, and likewise chronic bronchitis and emphysema. So as we all know, there are two principal conditions included when COPD is being discussed. We have, of course, chronic bronchitis and emphysema. So when you say chronic bronchitis, this is a chronic or recurrent excess mucus secretion with cough that occurs on most days for at least 3 months of the year or at least 2 consecutive years, or rather, to correct, at least 3 months of the year for at least 2 consecutive years. And when we say emphysema, this is an abnormal permanent enlargement of the air spaces, distal to the terminal bronchioles, accompanied by destruction of their walls without fibrosis. So the next slides and discussions will include an excerpt from the Global Strategy for the Diagnosis, Management, and Prevention of Chronic Obstructive Pulmonary Disease as presented and provided by the Global Initiative for Chronic Obstructive Lung Disease or GOLD. So our next discussion would include the different etiotypes of COPD. So when we talk about etiotypes, we have the following. So we have the genetically determined COPD, or what we call the COPD-G. So what would be the description of this particular class? So normally when a COPD is termed as COPDG, it is described as a possible alpha-1 antitrypsin deficiency or the AATD that we call. It can also warrant other genetic variants with smaller effects acting in combination. Next, we have the COPD due to abnormal lung development or the COPD-D. So basically, this is a COPD that happens early in life events. No? Like for example, due to premature birth and low birth weight, among others. Next is we have a general class, which is the environmental COPD. This is further divided to cigarette smoking COPD or the COPD-C and the biomass and pollution exposure COPD or COPD-P. So what would be the difference of the two? Obviously, when we say COPD-C or the cigarette smoking, this is attributed to exposure to tobacco smoke, including in utero or via passive smoking. It also includes vaping or e-cigarettes and cannabis use. Well, for the biomass and pollution exposure COPD, these are any exposure to household pollution, ambient air pollution, wildfire smoke, or occupational hazards. The next is the COPD due to infections, that is COPD-I. So basically, this can be either childhood infections, tuberculosis associated COPD, can also be the HIV associated COPD. Next is COPD and asthma, which is COPD-A. Particularly, this pertains to childhood asthma related COPD. And last but not the least, we have the COPD of unknown cause or the COPD-U, which is basically idiopathic. This particular etiotypes was adopted from Selly et al. 2022 and Stolz et al. 2022. Next is, let's talk about the pathophysiology of COPD. So if we look at the big picture for the development or the pathophysiology of COPD, normally it begins with inhaled noxious particles of gases. And such inhalational of these particles would lead to oxidative stress, can also lead to directly to inflammatory response, or an imbalance of proteinases and anti-proteinases. So basically, the oxidative stress can further lead to inflammatory response, and vice versa. The inflammatory response can trigger the oxidative stress. So generally, these three results would lead to the pathologic changes that would occur in COPD. So the pathologic changes is normally described as physiologic abnormalities. Now, when we say physiologic abnormalities, usually the presentation of these changes would be in order. So what are those abnormalities? First, we have mucose hypersecretion. Second, ciliary dysfunction. Third, airflow limitation. Four, hyperinflation. Fifth, gas exchange abnormalities. Next is pulmonary hypertension. And eventually, it will lead to a variety of systemic effects. Now, for the further discussion of this one, this will be related in our next slides and a separate video recording. So the main question is, if we have mentioned that COPD has inflammation, the question is, when we look at asthma and COPD, what would be the difference? Because if you can remember, when we discuss asthma, we also mentioned that it is, or part of its pathophysiologic occurrence is that there is an inflammation. Now, to answer this one, basically, asthma is mediated by eosinophils and mast cells. While for the COPD, the inflammatory reaction is mediated by neutrophils, macrophages, or CD4 plus lymphocytes. Now, I've mentioned in the previous slide that there are several factors that we would consider in terms of the COPD pathophysiology. And that would include, as mentioned, we have the chronic inflammatory changes, the inhalation of noxious gases and particles, oxidative stress, inflammatory exudate, smoking-related COPD, and vascular changes. So at this point, this particular discussion would be provided at a separate recording. So moving forward, let's focus on the clinical indicators for considering a diagnosis of COPD. So basically, the clinical indicators that I'm going to present are things that we would consider in order to check if a patient would be considered for COPD. And if that happens, it is recommended to perform spirometry. We should note that the clinical indicators are not diagnostic in nature. However, the presence of these multiple key indicators increases the probability of the presence of COPD. So it is really emphasized that we perform the spirometry or the proper diagnostic procedure for COPD. Now, the clinical indicators that are commonly present and would trigger us to consider COPD would include, first, we have dyspnea. Second, we have recurrent wheeze. Third, chronic cough, as we have mentioned in the definition, especially for chronic bronchitis. We have recurrent lower respiratory tract infection and the history of risk factors. So we have mentioned different etiotypes. So these are the things that we will try to look at as clinical indicators. And if they are present, we would consider COPD and again perform spirometry. Now, uh, going back to the slide, so if I may emphasize, what are the further characteristics of these clinical indicators? So first, for dyspnea, we would observe that it would be progressive over time. There is worsening during exercise or exertion, and the dyspnea would be very persistent. For the chronic cough, it can be intermittent in nature and may be unproductive. So once these characteristics are present, so those are minimum considerations. And again, for the history of risk factors, let me just emphasize, though it was discussed in the previous slide. So what are the things to note? Of course, tobacco use or cigarette smoking. So of course, we should also include the popular local preparations, cigarettes, vaping, stuff like that. Smoke from home cooking and heating fuels, especially if it's occupational related. Occupational dust, vapors, fumes, gases, and other chemicals. And of course, host factors, so such as genetic factors. Remember, we have a genetical link COPD, developmental abnormalities if it's in terms of childhood development, for low birth weight, prematurity, childhood respiratory infections, and the like. So these are the things or further details of these clinical indicators that we need to further investigate. So moving forward, what are the other causes of COPD? So other causes is further divided if it's intrathoracic. So meaning to say those that infect organs within the thoracic cavity or the respiratory system, which includes diseases such as we have asthma, bronchiectasis, cystic fibrosis, idiopathic cough, interstitial lung disease, left heart failure. No, that's very particular because we know that the left heart failure would affect the lungs or the pulmonary system, lung cancer, and of course, tuberculosis. So just like here in the Philippines, we also have to consider the epidemiology of these diseases. The second major other causes would be extrathoracic in nature, meaning to say other organ diseases that can contribute to the development of COPD. So we have chronic allergic rhinitis or chronic AR. We have GERD or gastroesophageal reflux disease. We also should consider medications such as the use of uh, angiotensin converting enzyme inhibitors. So yung may mga pril, so enalapril, perindopril, and the like. We also have the postnasal drip syndrome or the PNDS and the upper airway cup syndrome or the UACS. So what is the common clinical presentation for COPD? So again, when we say clinical presentation, it includes the pattern of the signs and symptoms. So initially, when we talk about CPD, the initial symptoms would include chronic cough and sputum production. But again, remember that in some cases, there would be unproductive cough. Patients may have symptoms for several years before dyspnea develops. So those are the initial symptoms. Now, if a physical examination will be performed, uh, it is mostly in physical examination, patients on milder stages would appear or would have normal results. Um, it is only by when airflow limitation becomes severe that mostly patients would present physical symptoms such as cyanosis of the mucous membranes, development of barrel chest, no, which is due to hyperinflation of the lungs. What else? Increased respiratory or resting respiratory rate, shallow breathing, we have pursing of lips during expiration, and the use of accessory respiratory muscles. So those are physical manifestations of a COPD. Now, in occurrences of COPD exacerbations, we can observe worsening of dyspnea or difficulty of breathing. There would be increased sputum volume, increased sputum purulence or the presence of pus. Other features would include chest tightness, no, obviously because there would be increase in mucus production, increased need for bronchodilators as this mucus would fill the lung branches. So it would lead for the patient to have difficulty of breathing, no, as we have mentioned. We have also malaise, fatigue, and of course, decrease in exercise tolerance. As we have said, that there are symptoms, especially cough, that can be triggered during exertion in the exercise. Now, for the diagnosis of COPD, basically diagnosis in part of the patient symptoms and history of exposure to risk factors should be considered, and that one of the first thing to look at is the clinical or the disease severity. So later on, I would lead you to the discussion of how to classify the disease severity of the COPD. But generally, these are based on assessment of airflow limitation. That's why spirometry is being used for the diagnosis. The measurement of symptom severity and assessment of exacerbation frequency can be assessed by the use of the COPD assessment test or the CAT, or we can also use the Modified Medical Research Council or the MMRC scale. So later on, I will be showing you this different diagnostic tests. Patients that are first classified, no, usually patients are first classified according to the severity of airflow obstruction. So normally this is graded 1 to 4, and then after such they will be regrouped as represented by group A, B, C, or D. However, later on in our discussion, I will be providing you the latest groupings that we have. So we no longer use the A, B, C, or D, or rather, what we use now is A, B, and E, or the ABE severity assessment. So those are the things that we will further discuss. Now, spirometry is needed, no, in the diagnosis of chronic pulmonary disease. And of course, this would include evaluation of the vital capacity, the forced expiratory volume, residual volume of the lungs, and similar interpretations. Likewise, arterial blood gases can also be assessed. So significant changes in arterial blood gases, although are not usually present until the forced expiratory volume is less than 1 liter. So once it happens, we would observe that there would be hypoxemia, hypercapnia, and those may become chronic, no, in nature. What else? Hypoxemia usually occurs initially with exercise, but eventually as the COPD progresses, even at rest, it can be observed. We also have ARF in COPD. When we say ARF, this is acute respiratory failure. And normally this is diagnosed based on an acute drop in the partial oxygen level, which is roughly around 10 to 15 millimeter per mercury, or if there is an acute increase in partial carbon dioxide levels that eventually decreases the serum pH to less than or equal to 7.3. So the manifestations of ARF in COPD would include the patient would manifest restlessness, confusion, tachycardia, diaphoresis, cyanosis, hypotension. Irregular breathing can also be seen, meiosis, and it may also present unconsciousness or lead to unconsciousness. So the most common cause of ARF is acute exacerbation of bronchitis, or if it also is coupled with increased sputum volume and viscosity. So basically, that would worsen the obstruction, eventually leading to the worsening of hypoxemia and development of the hypercapnia. So moving forward, these are the different differential diagnoses to consider for COPD. So we have asthma, congestive heart failure rather, bronchiectasis, tuberculosis, obliterative bronchiolitis, and diffuse panbronchiolitis. So there are things, no, or suggestive features in order to separate this differential diagnosis. Mostly when we talk about asthma, we would observe variable area obstruction. Normally, the symptoms may vary widely from day to day. So as we have discussed before with asthma, it can worsen at night or early morning. Remember, we have discussed the reason for that. It can also be associated with an asthma, allergy, rhinitis, or eczema. This usually occurs in children. And of course, if there's a family history of asthma, so those are things that we can consider to narrow it to asthma over COPD. For CHF, of course, if we have a radiologic result that presents dilated heart or pulmonary edema, which is basically a feature of left-sided heart failure, and also if a pulmonary function test would indicate volume restriction or but not airflow obstruction. For bronchiectasis, we would observe large volume of purulent sputum. Normally, this is very or this is related to bacterial infection. And of course, when we perform chest X-ray, it would present bronchial dilation. For the tuberculosis, well, basically the onset is at all ages, no, especially if there's a predisposal. The chest X-ray would show lung infiltrates, Microbiologic confirmation is very reliable. Of course, the acid fast testing, we also have the PPD tuberculin test. And then, of course, if we would like to survey the environment of the patient, if there would be a high local prevalence of tuberculosis. So for the obliterative bronchiolitis, normally it occurs in children, can occur rather in children. It is normally seen after a lung or bone marrow transplantation. And the high radiologic contrast would show that there are hypodense areas during expiration of the patient. And then, of course, if it's diffuse panbronchiolitis, normally this is if we talk about race, so this is normally predominant in Asian descent. Most patients are male and non-smokers. Um, Most of the patients, or almost all of the patients, do have history of chronic sinusitis. And on chest X-ray, it would show diffuse small centrilobular nodular opacities and hyperinflation. So those are the differential diagnosis with COPD. So the next part of the discussion would include, of course, what I have mentioned, the grading and severity assessment for COPD. Now, in this case, the gold grades and severity of airflow obstruction in COPD is based on post-bronchodilator forced expiratory volume. So in COPD patients, if the ratio of forced expiratory volume and the forced vital capacity is less than 0.7, um, the categories are, it's grade 1, mild, if it's the forced expiratory volume is equal or more than to 80% as predicted, as I've mentioned in the earlier slides. Gold 2 is moderate, about 50% less than or equal to forced expiratory volume and less than the predicted 80%. Gold 3 or the severe, which is around 30% or less than or equal to forced expiratory volume that is less than 50% as predicted. And the very severe gold 4 would be forced expiratory volume of less than 30% predicted. So we also mentioned that after classification of grading and severity, we can also use the modified MRC dyspnea scale. So this is the example of the scale that we are going to use. So as you can see, this is the MMRC grading. We have 0, 1, 2, 3, and 4. And then each grade is characterized by activity and symptoms. Like for example, for grade 0, I only get breathless with strenuous exercise. So the patient just need to tick in the box that applies to the current signs and symptoms. Remember, such would the patient would only tick one box only. So basically, we would follow which would have the greater alignment of signs and symptoms. Okay, so we also have the CAT assessment. So here, so if I may enlarge it, so for the instruction for each item below, place a mark X in the box that best describes you currently. Be sure to only select one response for each question. So like for example, I never cough. So is it 0, 1, 2, 3, up to 5, which is 5 is I cough all the time. So, and then we place here the mark number and represent it by the score. So the patient would need to answer the remaining questions. And then a total score would be provided. So how would the diagnosis, or how are we going to use this one? So based on the GOLD AB assessment tool, this is the updated version. This is the 2023 version. So first, as we have said, spirometry will confirm the diagnosis. So that would include the post-bronchodilator result. of the ratio of forced expiratory volume and forced vital capacity that is less than 0.7. After that, we assess the airway obstruction. Again, we use the grading for the GOLD and the severity as I have discussed in the previous slide. And then we assess for the symptoms and risk of exacerbation. So this is how we classify it to A, B, and E. So if I may enlarge it, so this is how it looks like. So under the exacerbation history, this is per year, so you will quantify. Is it more than 2 moderate exacerbations or more than or equal to 1, but it led to hospitalization? If that is the case, it's E. So exacerbation of history versus the symptoms. So here is where we get the score from the MMRC and the CAT. Okay, so it's E. Normally, of course, we would prefer, like for example, there would be sometimes occasions that there would be conflicting results. So it's much safer that we categorize them on which is much clearer or much nearer data, so as to provide a better treatment modality. So coming from here, okay, what are the other investigations that we can provide or we can use rather? So we can also use chest X-ray. The main purpose of this one is to exclude other pathologies, no, the differential diagnosis. For the CBC, it's also to consider if the patient has anemia or polycythemia. This is to assess if there are blood-related factors to the development of the COPD. Because remember, if there is anemia, there would be decreased oxygen capacity, carrying capacity of the blood. Thus might lead to symptoms manifesting difficulty in breathing. Third is serial domiciliary peak flow measurement. So this is to exclude asthma if there is a certain doubt on the diagnosis. So number 4, we have alpha-1 antitrypsin. This is particularly used with early onset disease or if the patient had minimal smoking or family history factors. Number 5, we have transfer factor for carbon monoxide. This is to investigate symptoms that seem disproportionate to the spirometric impairment. So just what I have mentioned, sometimes the spirometry would give this, but the patient would have a different manifestation or other signs and symptoms. So this is used to confirm the diagnosis. So number 6 is CT scan of the thorax. So this is to investigate symptoms again that are, of course, disproportionate or unparalleled to the spirometric results. And also if there are other impairments that were seen or abnormalities that are seen in the chest X-ray, so to validate. Also, likewise, this is used if a patient is being assessed for suitability for surgery. 7 ECG is to assess cardiac status. Remember, we have also a condition called cor pulmonale. So if we would rule out such, echocardiogram would do the same. No, it would assess cardiac status. Number 9, pulse oximetry. This is to assess the need for oxygen therapy, especially if cyanosis or cor pulmonale is present, or if the forced expiratory volume is less than 50% of the predicted value. And sorry, last but not the least is sputum culture. Remember, we have to consider some infections such as tuberculosis. And of course, assessment of the sputum would give us data if we are really considering COPD, and of course to address the source of the uh, purulence and presence of mucus production. So again, for therapeutics, we would also go back with the goals of treatment. So there are two main goals of treatment for COPD: reduce the symptoms and reduce the risk. So further, how do we reduce the symptoms? It can either be a relief of the symptoms or such as palliative improve exercise tolerance, and improve health status, basically. And to reduce the risk, we prevent disease progression, we prevent and treat exacerbations, and of course, we reduce mortality. So for the management of COPD, so basically, this is the algorithm. So from the diagnosis based on symptoms, risk factors, and of course the spirometry. So we will conduct an initial assessment that would include again grading of the severity, and then we can use the assessment of CAT, MMRC, and exacerbation history, all incorporated under the process of the GOLD ABE assessment tool. And we look at smoking status, alpha-1 antitrypsin, and other comorbidities or the other possible differential diagnosis that we have mentioned. Now, if such would happen, okay, so what are we going to do? So initial management would include, of course, smoking cessation. That tobacco smoking is one of the factors. Vaccination, no, we have several vaccines available. Active lifestyle and exercise. Initial pharmacotherapy, so we'll mention that later. Self-management education, such as risk factor management, genetics, environment. Inhaler technique, this is very important, and we need to emphasize this since our patient would be largely dependent on their devices. And then breathlessness, written action plan is also good. And then manage the comorbidities because comorbidities will exacerbate COPD. So once done with the initial management, we can do the following. So we need to review what are the symptoms as presented in the CAT or MMRC as we have discussed. If there are exacerbations, the current smoking status, exposure to other risk factors, environmental, occupational, inhaler technique and adherence. Again, this is greatly important. That's why pharmacists are, the role of the pharmacist is very vital, especially yung teaching and communication to patients in COPD. Physical activity and exercise, need for pulmonary rehabilitation, self-management skills, need for oxygen, management of comorbidities, and of course, spirometry at least annually. And then after we review that, we adjust the pharmacotherapy and non-pharmacological therapy for the patient and again perform the review. So that would be the process. Now for the initial management, so from our grouping, is it group A, group E, group B? These are the recommended treatment. So for group E, if the patient is classified under group E, we consider long-acting beta agonists and long-acting anti-muscarinic agents. If blood eosinophils is more than 300, we need to consider adding corticosteroids. For group A, we consider a bronchodilator, and for group B, a LABA and LAMA. So remember that in group E and group B for the LAMA, a single inhaler therapy may be more convenient and effective than multiple inhalers. So if we look at it at a um, how they say that a practical way, of course, if the patient would have difficulties or inability to use or adhere to their inhalers, that would be a very factorial thing to consider in the possible medication problems of the patient and therapy failure for that matter. So when initiating ICS to treatment, these are the factors to consider when we add this ICS to long-acting bronchodilators. So note that the scenario is different when considering ICS withdrawal. So first, we strongly favor the use of ICS if there are history of hospitalization for exacerbation of COPD, more than 2 moderate exacerbation of COPD per year, blood eosinophils of more than 300 cells per microliter, and history or concomitant asthma. And we have mentioned uh, earlier in our previous discussion that ICS is the preferred treatment for asthma. And then favors use if there's one moderate exacerbation of COPD per year and blood eosinophils is around 100 to 300 cells per microliter. Now, we are against the use of ICS if there is repeated pneumonia events, blood eosinophils of less than 100, and history of mycobacterial infection. Remember that ICS can predispose fungal infection, and as we have mentioned before, it would be closely related to what they call this Candida albicans. Okay, so for the management cycle, so again, we review the symptoms, the dyspnea, and of course the exacerbation. So we assess the inhaler technique and adherence of the patient, and of course the other non-pharmacological approaches, such as pulmonary rehabilitation and self-management education. And then once this is started and the patient is on treatment, of course, we need to conduct further review and assessment and evaluation so we can provide proper adjustment. So since the therapy would take would be on a cycle and would take time, uh, in most cases a lifetime, so there is a need to frequently assess and make necessary adjustments. So if there would be an escalation of the treatment regimen, is there a need to switch the devices or the molecules, especially that every now and then there are new devices would that have or can present greater advantages in therapy. So we can consider that so we can maximize it. And of course, we can also de-escalate or to try to do tapering or adjustment of other medications. So for the follow-up pharmacological treatment, so what would be our steps? So first, if response to initial treatment, as we have mentioned, is appropriate, we just need to maintain it. Okay. So we go to the cycle of symptoms, assess, and then review. Do we need to escalate? Do we need to maintain? Do we need to de-escalate? And so on and so forth. Now, in number two, if the patient is not responding to the initial treatment, we do not stop. We first check the adherence, the inhaler technique of the patient, and other possible interfering comorbidities. Next is we consider the predominant treatable trait to target, such as dyspnea or exacerbation. So use exacerbation pathway for both exacerbation and dyspnea need to be targeted. Place patient in box corresponding to current treatment and follow indications, assess response, adjust and review, as we have mentioned, and uh, we need to also look further beyond the AB assessment and diagnosis. So for dyspnea, so again, we mentioned it can be used LABA or LAMA or a combination. So to consider switching inhaler device or molecules if it's not the patient is not responding, implement or escalate non-pharmacologic treatments and investigate and treat other causes of dyspnea. Remember, in LAMA, single inhaler therapy may be more convenient and effective than multiple inhalers. So it's nice, especially for pharmacists, to step in and make proper recommendations on the available preparation. So that is very vital because as pharmacists, we are very knowledgeable on the preparations available, the new innovations, and other developments. So we need to really provide information proactively, not just to the patients, but also to our doctors. And then if it's exacerbation, we consider the use of LABA or LAMA. Again, we consider the levels of eosinophils. So the level of eosinophils would warrant the inclusion of the ICS. And then if the forced expiratory volume is less than 50% and as the patient has chronic bronchitis, we can consider adding roflumilast. And also, if the patient is a former smoker, we could consider azithromycin. Okay, so just a note on these levels. When we say exacerbation, they refer to the number of exacerbations per year. Okay. So for non-pharmacological management based on the grouping of the patient, so if it's group A, we can have smoking cessation. This is very essential. Recommended physical activity, and depending on local guidelines, so we can consider different vaccinations. So we have flu vax, pneumococcal vaccine, and others. So we also have COVID-19 vaccines, no? So you have to be updated because, of course, still we have concerns on COVID-19. And then for groups B and E, smoking cessation and pulmonary rehabilitation, physical activity for the recommendation, and also a look at the different local guidelines on vaccination scheme. Okay, so yeah, I just enlarged this one. Sorry. So follow-up for the non-pharmacological treatment. So how do we go about it? If response to initial treatment is appropriate, maintain it and offer flu vaccination every year. So in other recommended vaccination per the guidelines in the local area. So the self-management education, especially with the use of the devices, and assessment of behavioral risk factors such as smoking cessation and environmental exposure. So we need to ensure that there is maintenance of exercise program and physical activity and adequate sleep and healthy diet. Now, if not, consider predominant treatable trait to target. Is it dyspnea or exacerbation? So we have here the recommendations. So remember that all patients with advanced COPD should be considered for end of life and palliative care support to optimize symptom control and allow patients and their families to make informed choices about future management. So here in the Philippines, if you would look at COPD, there are a lot of avenues wherein pharmacists can add their expertise into helping to improve the management of our COPD patients. So for confounders to suspected COPD exacerbations, we have the following. For most frequent, we have pneumonia. So we look at chest radiography to confirm that pulmonary embolism. So clinical probability assessment check, hemoptysis, did the patient underwent surgery, fractures, history of cancer, do they have DVT or deep vein thrombosis? We assess the levels of D dimer, so for the thromboembolism. And then, of course, CT angiography for pulmonary embolism. Also for heart failure. So again, chest radiography. So we check. We also look at anti-probrain natriuretic peptides, proBNP and BNP. So these are one of the key blood factors that we assess in heart failure, and of course, echocardiography. For the less frequent confounders, we have pneumothorax and pleural effusion. So ultrasound of the thorax and chest radiography can help us assess for these confounders. And myocardial infarction and or cardiac arrhythmias, such as atrial fibrillation and flutter. So we can assess the troponin. So remember in myocardial infarction, so troponin is one of the blood enzymes that we can assess, or blood camps that we can assess if there is a occurring myocardial infarction, and of course ECG. So for the diagnosis and assessment of suspected COPD exacerbation, these are the following things to do. May I note that, of course, the diagnosis would not be the primary work of the pharmacist. So the main purpose of why we are discussing this in pharmacotherapeutics is that as pharmacists, we need to understand the process so that if our help or contribution in terms of our recommendation for therapies being sought by the healthcare professionals, we would also know where in the process we would insert this recommendation. So timely recommendations and appropriate recommendations are also vital. So here is the assessment and COPD exacerbations. Okay. And we need to evaluate the severity again and, of course, establish the cause of the event. Is it viral, bacterial, environmental, or others? So, COPD exacerbation is also being classified. So, if I may enlarge this one, so COPD patient with suspected exacerbation, we need to confirm the diagnosis and episode of severity. So, first, we look at the severity. So, for mild default, so these are the values or the variable thresholds to determine of this the severity. Okay. We also have moderate. Uh, the requirement is that it meets at least 3 of 5 of the different symptoms provided here, signs and symptoms. And for severe. Now, after which we look at the severity, we determine the etiology by the use of viral testing, sputum culture, and others. So this is to assess if it's viral, bacterial in nature. Then next, we consider differential diagnosis. So is there heart failure, pneumonia, pulmonary embolism, as and all the other differential diagnoses that I've mentioned. And after such, we provide the appropriate testing and treatment of the other comorbidities. So for hospital assessment and potential indications, these are the following. So I wouldn't be discussing each one because it's already highlighted here. What are the further examples of each entry? And then management of severe but not life-threatening exacerbation would include the following. So, of course, as you can see, there's always the assessments of severity. Okay. Administer supplemental oxygen. Arterial blood gases should be checked. Venous blood gases, pulse oximetry. Here we have bronchodilator. So it's possible that we increase dose and frequency of the short-acting bronchodilators, combine short-acting beta-2 agonists and anticholinergics, and also consider use of long-acting bronchodilators when patient becomes stable. Uh, I failed to mention to highlight the use of spacers or air-driven when appropriate. Okay. Devices. Consider oral corticosteroids, oral antibiotics if there's a possibility of bacterial infection. Consider non-invasive mechanical ventilation, which is NIV. And at all times, we need to monitor fluid balance. Consider subcutaneous heparin or low molecular weight heparin for prophylaxis to thromboembolism, and identify and treat associated conditions. So at this point, you would like to see that even though the diagnosis is COPD, because the condition itself would predispose other diseases, that's why sometimes when you look at the therapeutic management of the patient, you would see other medications that are that are not expected to be there. Like for example, heparin. So initially, you wouldn't be expecting heparin to be part of a COPD treatment. However, when there is exacerbation and there's the severity, and if there's the risk of the patient developing thromboembolism, then you would have to monitor and consider such treatment. And then discharge criteria and recommendation for follow-up. So full review of the all clinical and laboratory data. Check maintenance therapy and their understanding. So again, this is vital that pharmacists are able to teach the patients on the proper use of their devices. Reassess inhaler technique. Okay, so nowadays we have a device that basically allows us to determine the technique of the patient and allow us to objectively assess if there's a need to change or improve the inhaler technique of the patient. So I have added the video link onto your Neo LMS. Ensure understanding of withdrawal of acute medications such as steroids and antibiotics. Again, no, for pharmacists to emphasize the proper taking of antibiotics, not just for the completion, but of course, we would like to prevent resistance. For the steroids, we know that if we abruptly stop the steroids, it will produce withdrawal symptoms. And then we need to assess need for continuing oxygen therapy. That would be for the clinicians. Provide management plan for comorbidity. So for pharmacists, additional things to take note is, of course, we need to assess also for drug interaction and medication problems. And then to ensure follow-up arrangements and to emphasize that the importance of going back for follow-ups. And of course, all clinical or investigational abnormalities have been identified. So, meaning to say that we don't have gray parts on the treatment. So, for the follow-up on weeks 1 to 4 and 12 to 16 are emphasized here, elaborated rather. So for the interventions, so these are the recommended interventions based on frequency of exacerbations. So we have bronchodilators, we have corticosteroid containing regimens, anti-inflammatory, which is non-steroid, you have roflumilast, anti-infectives, we also have vaccines and long-term macrolides, mucoregulators, and acetylcysteine, carbocysteine, erdocysteine, and various other factors such as smoking cessation, rehabilitation, vitamin D, as we all know, and then shielding measures like wearing face masks and the like. So these are the risk factors to development of lung cancer. And then, since we are still in the pandemic and we have to consider the presence of COVID-19, so how do we manage stable COPD in the presence of COVID-19? So for protective strategies, follow basic infection and control measures, face masks, covering. We need to consider shielding and, of course, have COVID-19 vaccinations in line with national recommendations, of course. For the investigation, only essential spirometry at times of high prevalence of COVID-19. Pharmacotherapy ensure adequate supplies of medication to the maintenance treatment of the patient and continue unchanged, including the ICS. For non-pharmacological, annual influenza vaccination and maintain physical activity. So here, we are to compare COPD and COVID-19 in terms of clinical features. So COPD patient not infected, so COPD cough and shortness of breath. If there is mild COVID-19, so there is mild constitutional symptoms. So meaning to say constitutional, the expected symptoms. And then dyspnea infiltrates, and then acute respiratory distress syndrome would set in. And as you can see, this can predispose to shock, cardiac failure, and then if it's a convalescent COVID, we can see fatigue, SOB, and cough. So abnormal investigations are also provided here. Now for the possible intervention, so again, if it's non-confirmed, home exercise, protective strategies, and so on and so forth. And of course, we need to continue the usual COPD maintenance therapy. So most of these are add-ons or there is emphasis to providing more of this therapy. So this is adopted from the American Thoracic Society. So what are the key points in the management of COPD and COVID-19 all the same? So first is SARS-CoV testing, of course, swab or saliva PCR. So especially if there's worsening of respiratory symptoms, so we can confirm if it's really COVID related. So other investigations such as remember, avoid spirometry unless essential. The concern here is, of course, the possible spread of COVID-19. So again, if it's just essential, then consider CT for COVID pneumonia and to exclude other diagnoses. Avoid bronchoscopy and assess for co-infection. For the pharmacotherapy, of course, insurance of acute supplies, continue medication therapy, use of antibiotics and oral steroids in line with recommendation of exacerbation. And in terms of nebulization, as initially recommended, we need to avoid it because this would possibly produce mist that can predispose the spread of COVID-19. For non-pharmacological therapy, we have to maintain physical activity as able. And here are the other protective strategies. And of course, we also have to evaluate the COVID-19 therapy for the patient. So here is an example of the COPD follow-up checklist. So if they are going to come back for their the week 1 to 4 and the 12 to 16. So the patient just have to answer the following boxes. So we have here the baseline symptoms, the COVID-19 symptoms, the written action plan, recent admissions and emergencies, if there are, COPD self-management assessment, and of course, comments and main issues, then summary interventions in plan. That's all. Thank you. So may I also emphasize the different references used in this presentation? You have Global Initiative for Chronic Obstructive Lung Disease, or GOLD, for our several slides, especially starting from the treatment, management, and assessment and diagnosis. We have pharmacotherapy principles in practice. We also have principles of pharmacology, clinical pharmacy and therapeutics, and pharmacotherapy handbook, and physical assessment in patient assessment in clinical pharmacy. Again, thank you.